Welcome to this Step 2 clinical knowledge review on connective tissue diseases test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will see on your board exam for connective tissue diseases, including systemic lupus erythematosus, scleroderma, Sjögren's syndrome, and mixed connective tissue disease. The goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the rheumatology and immunology sections of first aid and your question bank before or alongside this video. Let us get started. Here is what we are going to cover today. First, we will learn to recognize the high-yield question stems for connective tissue diseases that show up repeatedly on the boards. Second, we will apply specific test-taking strategies for lupus, scleroderma, Sjögren's syndrome, and mixed connective tissue disease questions. Third, we will master the next best step question format for diagnosis and management. Remember, this video assumes you have already reviewed the rheumatology and immunology chapters in first aid and your question bank. We are here to sharpen your test-taking skills, not replace your foundational studying. Our first strategy is the antibody pattern split. When you see a connective tissue disease question, the very first thing you want to identify is the antibody pattern. For lupus, the buzzwords are a young woman with a butterfly-shaped malar rash, joint pain, fatigue, and serositis. The key antibodies are anti-double-stranded deoxyribonucleic acid and anti-Smith, which are both specific for lupus. You will also see low complement levels and a positive anti-nuclear antibody test. For scleroderma, look for skin thickening and renal phenomenon. The critical distinction the boards test is between diffuse and limited scleroderma. Anti-topoisomerase 1, previously called anti-SCL70, points to diffuse disease with internal organ involvement. Anti-centromere antibodies point to limited disease, the calcinosis, renal, esophageal dysmotility, sclerodactyly, and telangiectasia syndrome. This antibody split is one of the highest yield distinctions you can memorize. Review the autoantibody tables in first aid for the complete picture. Strategy 2 focuses on recognizing the overlap features between these diseases. Sjögren's syndrome has a very recognizable stem on board exams. You will see a middle-aged woman, typically in her 40s or 50s, complaining of dry eyes and dry mouth, which we call Zika symptoms. The key antibodies are anti-Rho and anti-Le, also referred to as anti-Sjögren's syndrome A and anti-Sjögren's syndrome B. An important board pearl is the association with parotid gland enlargement and an increased risk of non-Hodgkin lymphoma. For mixed connective tissue disease, the question stem will describe a patient with features from multiple connective tissue diseases at the same time. You might see Raynaud phenomenon from scleroderma, joint pain from lupus, and muscle weakness from polymyositis, all in the same patient. The defining antibody is anti-ribonucleoprotein. When you see overlapping features plus a question about which antibody to order, think mixed connective tissue disease. Review the rheumatology section of your question bank for practice questions that test these overlap patterns. Now let us talk about high-yield stem recognition. These are the classic question patterns you will encounter. For lupus nephritis, the stem will describe a young woman with known lupus or classic lupus features who now has proteinuria, hematuria, or rising creatinine. The boards want you to know that renal biopsy is the next best step to classify the type of nephritis and guide treatment. For scleroderma renal crisis, you will see a patient with diffuse scleroderma who suddenly develops severe hypertension and acute kidney injury. The critical board pearl here is that the treatment is an angiotensin-converting enzyme inhibitor. The boards specifically test this because many students incorrectly choose a calcium channel blocker or other antihypertensive. For drug-induced lupus, the stem will mention a patient on hydralazine, procainamide, or isoniazid who develops joint pain and serositis. The distinguishing feature is positive antihistone antibodies with negative anti-double-stranded deoxyribonucleic acid antibodies. Symptoms improve when the offending medication is discontinued. Review the pharmacology tables in first aid for the full list of drugs that cause drug-induced lupus. Here is our first practice question. Take a moment to read through the stem carefully. We have a 25-year-old woman with fatigue, joint pain, and a facial rash that spares the nasolabial folds, which is the classic butterfly or malar rash of lupus. Her labs show a positive anti-nuclear antibody, elevated anti-double-stranded deoxyribonucleic acid antibodies, and low complement levels. But the critical finding here is the urinalysis showing proteinuria and red blood cell casts. This tells you there is renal involvement. Think about what the most appropriate next step would be before we go to the answer walkthrough. Let us walk through this answer step by step. Step 1. Spot the pattern. We have a young woman with a malar rash sparing the nasolabial folds, joint pain, positive anti-nuclear antibody, elevated anti-double-stranded deoxyribonucleic acid antibodies, and low complement. This is textbook systemic lupus erythematosus. But the question is not asking you to diagnose lupus. It is asking about the next step in management, given the renal findings. Step 2. Apply the rule. When you see proteinuria and red blood cell casts in a lupus patient, that is lupus nephritis until proven otherwise. The board rule is that you need a renal biopsy to classify the nephritis because the treatment differs based on the class. Step 3. Eliminate the wrong answers. Hydroxychloroquine is important for long-term lupus management but does not address acute nephritis. Starting high-dose steroids empirically is tempting but incorrect because you need to know the class of nephritis first. Ordering anti-Smith antibodies would confirm lupus, but the diagnosis is already clear and it does not change management. The correct answer is B. Obtain a renal biopsy. This is a classic board testing point. Review the lupus nephritis classification in your rheumatology resources. Here is our second practice question. Read through this stem carefully. We have a 52-year-old woman with a history of diffuse skin thickening and Raynaud phenomenon, which tells you she has diffuse scleroderma. She presents with sudden severe hypertension, a dramatically elevated creatinine, and schistocytes on peripheral smear. Think about what diagnosis this represents and what the most appropriate initial treatment would be. Let us walk through the answer. The key to this question is recognizing scleroderma renal crisis. The triad is diffuse scleroderma plus sudden severe hypertension plus acute kidney injury. The schistocytes on the peripheral smear confirm microangiopathic hemolytic anemia, which is part of the picture. Now for why angiotensin-converting enzyme inhibitors win. This is one of the most tested points in rheumatology. Angiotensin-converting enzyme inhibitors like captopril are the first-line treatment for scleroderma renal crisis and have been shown to significantly improve survival and renal outcomes. Intravenous nitroprusside would treat hypertensive emergency in general, but is not first line for scleroderma renal crisis. Oral nifedipine is used for Raynaud phenomenon, but not for renal crisis. Intravenous cyclophosphamide is used for scleroderma-associated interstitial lung disease, not renal crisis. The correct answer is C, oral captopril. This is a must-know board fact. You will find detailed coverage of scleroderma renal crisis in the rheumatology and nephrology sections of your review resources. Let us review the key treatment pearls that are most commonly tested on the boards. For lupus, hydroxychloroquine is the backbone of treatment. It should be used in nearly all lupus patients and has been shown to reduce flares, prevent organ damage, and improve survival. For lupus nephritis specifically, treatment depends on the biopsy classification. Severe forms like Class 3 and Class 4 proliferative nephritis require immunosuppression with mycophenolate mofetil or cyclophosphamide. Corticosteroids are used for acute flares but should be minimized over time due to side effects. For scleroderma, the treatment you must know is angiotensin-converting enzyme inhibitors for renal crisis. For interstitial lung disease associated with scleroderma, mycophenolate or cyclophosphamide is used. For Sjögren's syndrome, the treatment is primarily symptomatic. Artificial tears for dry eyes and saliva substitutes for dry mouth. Hydroxychloroquine can help with the joint pain and fatigue that accompanies Sjögren's syndrome. You can find detailed treatment algorithms in the rheumatology chapters of First Aid and your question bank. Here is our third practice question. We have a 48-year-old woman with 6 months of dry eyes and dry mouth. She also has bilateral joint pain and fatigue, with bilateral parotid gland enlargement on exam. Her labs show a positive anti-nuclear antibody and elevated erythrocyte sedimentation rate. Think about what diagnosis this points to and what the most appropriate next diagnostic test would be. Let us walk through this answer. Step 1. Spot the classic pattern. We have a middle-aged woman with the sicker symptoms of dry eyes and dry mouth, bilateral parotid gland enlargement, joint pain, and a positive anti-nuclear antibody. This is the textbook Sjögren's syndrome presentation. Step 2. Know the diagnostic approach. The first serologic test to order when you suspect Sjögren's syndrome is anti-Rho and anti-LE antibodies, also called anti-Sjögren's syndrome A and anti-Sjögren's syndrome B. These are the most specific serologic markers for Sjögren's syndrome. Now let us eliminate the wrong answers. Anti-double-stranded deoxyribonucleic acid antibodies are specific for systemic lupus erythematosus, not Sjögren's syndrome. Rheumatoid factor can be positive in Sjögren's syndrome, but it is not specific enough and is also positive in many other conditions. Lip biopsy of the minor salivary glands is a valid diagnostic test for Sjögren's syndrome, but it is typically performed when serologic tests are negative and clinical suspicion remains high. Serology comes before biopsy in the standard workup. The correct answer is B, anti-Rho and anti-LE antibodies. Review the Sjögren's syndrome diagnostic criteria in your rheumatology resources for the complete workup algorithm. Here is one of the most important test-taking pearls for connective tissue diseases, the autoantibody quick reference. The boards test antibody disease pairs constantly, so having these memorized will save you significant time on exam day. Let me run through the key pairs. For lupus, it is anti-double-stranded deoxyribonucleic acid and anti-Smith. For diffuse scleroderma, it is anti-topoisomerase 1. For limited scleroderma, it is anti-centromere. For Sjögren's syndrome, it is anti-Rho and anti-LA. For mixed connective tissue disease, it is anti-ribonucleoprotein. And for drug-induced lupus, it is anti-histone. Why does this matter so much on the exam? Because many questions are designed so that recognizing the correct antibody immediately gives you both the diagnosis and the answer. You can often answer these questions in under 30 seconds if you have the antibody pairs memorized cold. I strongly recommend building a flashcard set for these pairs and reviewing them until they are completely automatic. You will find a comprehensive autoantibody table in the immunology and rheumatology chapters of first aid. That wraps up our review of connective tissue diseases test-taking strategies for Step 2. Let me leave you with some final tips. First, always go back to your foundational resources. Review the rheumatology and immunology chapters in first aid and work through the connective tissue disease question blocks in your question bank. Focus on autoantibody patterns, organ-specific complications, and the treatment algorithms we covered today. Second, if you found this video helpful, please like and subscribe to our channel for more high-yield board review content. We release new test-taking strategy videos regularly covering the most tested topics on Step 2. Third, if you want personalized tutoring or guidance on your residency application, check out our expert tutors and residency advisors at roadmap2residency.com. We are here to help you succeed on your boards and match into your dream residency. Good luck on your exam, and we will see you in the next video.